All right, team, let's jump right in. Today, we're going to take just one single symptom and follow the breadcrumbs all the way from the biologic why down to the life-saving action you need to take. You ready? Let's do this.
Okay, so picture this. It's a classic scenario you're going to see all the time. Your patient is in agony after having a couple slices of pizza for dinner. And sure, we could just throw some pain meds at the problem, but to really be a great nurse, you've got to ask that deeper question. What's the real biologic reason this is happening? We're going to solve this puzzle together.
All right, so let's meet our patient at the center of all this, Tanisha Smith. She's 37 years old, and she's been admitted with severe pain in her right upper quadrant. That's their chief complaint, right? The very first clue in our whole investigation. And this right here, this is the core of what makes a nurse an expert, uncovering that biologic why. See, it's not enough to just know what's happening. You have to understand why it's happening. I mean, deep down at the physiologic level. That's how you connect the dots from a simple symptom to the full-blown disease process.
Okay, so let's get our whiteboard out basically and map this thing out. So, step one, the pizza. It's a high-fat meal, right? That's the trigger that tells the gallbladder, hey, time to squeeze and send out some bile to digest this fat. But here's the problem. There's a blockage. Gallstones are literally plugging up the biliary duct, so the bile has nowhere to go, it's trapped. That's the mechanical failure at the heart of everything.
And you know, this one blockage, it sets off a whole cascade of bad stuff downstream. So first, that duct starts to spasm like crazy, and that's what's causing her intense pain in that right upper quadrant. Then, because the bile can't get where it needs to go, into the intestines, that fat from the pizza isn't getting digested. The result? Steatorrhea. You know, those fatty stools. And finally, think of it like a traffic jam. Everything backs up, including the pancreatic enzymes. And that leads us straight to our lab results.
And boom, a look at her labs totally confirms what we're thinking. Her amylase and lipase, you know, those two key pancreatic enzymes, they're both way up. This is the hard data, the biochemical proof of that backup we were just talking about. See, all the puzzle pieces are starting to snap into place.
Okay, so at this point, we have a really clear picture of the why, right? The pathophysiology is making sense. But here's the thing. In a real acute care setting, just knowing isn't enough. It's all about action. So the next most important question is, what do you do first? What is your absolute #1 priority the second you walk into her room? To figure that out, let's use a great mental model I call the acute care assessment triangle. So think of it like this. At the very bottom, the foundation of everything you do is safety. That's the base. Then you've got the structure, which is your big systematic bedside assessment. But when you're in a crisis, like with Tanisha right now, you don't start at the bottom. You have to go straight to the top of that triangle, right to the point.
And what's at the point? The focused assessment. Look, this is not the time for a leisurely, hour-long head-to-toe. No way, we've got to move fast. You've heard it before, time is tissue. We need to zero in on the immediate crisis, her crazy abdominal pain, and the systems it's affecting, so we can identify the problem and deal with it like right now. Okay, and for all of you studying for the NCLEX, listen up. This is a huge exam alert. A classic trap answer they'll throw at you is, begin a comprehensive head-to-toe physical assessment. It sounds thorough, it sounds right, but for a patient in acute distress, it is absolutely wrong. Don't fall for it. The real priority action, the next-gen answer, is always the focused assessment that hones in on the immediate life threat.
But hold on a second. Before you even think about putting a stethoscope on the patient, what's the one thing you have to do first? Let's go all the way back to the base of our triangle. You have to check the environment. Check for safety. This is all about preventing those awful never events.
This is like your non-negotiable 5-second scan the moment you walk through the door. Is that her correct ID band? Check. Is the allergy band on and is it accurate? Check. Is the bed in the lowest position? Is the call bell right there where she can grab it? These super simple checks can literally prevent catastrophic errors.
And listen, this is way more than just a box to tick. You absolutely 100% cannot give a single medication until you have physically looked at that wristband and verified her identity and her allergies. No shortcuts.
And speaking of meds, let's see what's ordered for Tanisha. Okay, we've got acetaminophen for pain and dicyclovirin. That's an antispasmodic. This is a perfect example of how pharmacology directly targets the pathophysiology, right? The dicyclovirin is designed to stop those biliary spasms that are causing all that agony.
All right, so while you're doing your focused assessment on a patient in distress, you've always got to be on the lookout for red flags in other systems. And here's another big one for your exams. One of the most critical places to look is the peripheral vascular system.
You have got to know the 6 Ps of ischemia like the back of your hand. I mean, know them cold, okay? Let's run through them. Pain, pallor, that's paleness, poikilothermia, which is just a fancy way of saying the limb is cool to the touch, pulselessness, paresthesia, that pins and needles feeling, and finally, paralysis. If you find any of these, this is a full-blown, limb-threatening emergency. You don't wait, you don't chart it and come back in an hour. You get the provider on the phone immediately.
All right, we've covered a lot of ground, so let's do a super fast 30-second recap of that whole clinical judgment flow. Okay, so here it is, the whole clinical judgment model, using Tanissa's case from start to finish. First, you recognize the cues. Are you Q pain after that fatty meal, the vomiting, the steatorrhea? Then you analyze those cues, right? You connect the dots to a gallbladder problem. Step 3, you prioritize your hypothesis. Acute cholecystitis is the most likely and most dangerous thing happening. So you generate solutions. We need a focused assessment, a safety check, and pain management. Then you take action, you give the dicyclovir and acetaminophen, but only after you've verified her allergies. And last, you evaluate the outcomes. Is her pain getting better? Are her vitals stable? That right there is the complete loop of expert nursing care.
So, you've nailed it. Tanasia's pain is under control, her vitals look good, and you've got her on the right track. But clinical judgment never really stops with just the physiology, does it? So here's a final thought I want to leave you with. What kind of hidden risk, something buried deep in her social history, could come along and completely unravel this perfect plan of care you've created the second she walks out of the hospital? That's the next puzzle for you to solve.